session, and that is session 2 for the day, and last session of this INASL 2025 in Hall 2. I am delighted to invite on stage for the session on critical care hepatology. Chairpersons are requested to join me on stage: Dr. C.E. Appen, Dr. R.R. Sharma, Dr. Rakhi Mehwal, and Dr. Shweta Singh. Please grace the dais with your presence. The energy of INASL 2025 is extraordinary. Thanks to each one of you. For a valedictory session, you are requested to join us after the session gets over in Hall 1, that is the Crystal Ballroom at the ground floor. And over to the chairpersons to initiate this last session. Thank you.
So I would like to invite Dr. Acharya, sir, please, to come and tell us about the changing etiology and mortality of acute liver failure in India.
Thank you, Chairperson, sir, and thank you, Ajay and INASL for calling me. I thought the EPAN has forced them to tell me this, because EPAN is the first man to tell me that, look, Subrat, you are speaking nonsense. We don't see hepatitis viruses. We see rodenticide poisoning. That is the cause of acute liver failure. So, ladies and gentlemen, we know what is all acute liver failure, right? And we know the definition of acute liver failure. I will not take much time. I think 5 to 7 minutes I will finish my talk. And we have already defined it. We are provided in the consensus meet. Yes, well, patient with severe acute liver injury with a prolonged INR having mental abnormality, we defined as acute liver failure, particularly acute liver injury in patients who do not have previous liver diseases. There are regional differences, there are subclassifications, and we did not discuss that. For us, it is acute liver injury, and within 4 weeks, developing encephalopathy with a prolonged INR is acute liver failure. And a series of studies from this country during last 25 to 30 years, and probably initiated when I was very young, and I started working on this, has been summarized in many multiple studies, which I summarized in one slide. Till date, we all thought hepatitis viruses are predominant cause of acute liver failure in our patients, in about 90% of patients in various publications. And drugs constitute about 5 to 15% of patients, and predominantly anti-tubercular drugs are the major offender for acute liver failure, and particularly given when they are not indicated. Paracetamol was infrequent and till now probably infrequent. Rat poison, that is rodenticide poison, and Dr. Epan actually started the ball rolling, right? And also started saying the low volume plasma exchange improves them and has become important cause of acute liver failure in South India, particularly Tamil Nadu. If you see in this slide what I pointed out, hepatitis B virus being the common cause, the mortality was etiology specific. We had predominantly hepatitis E virus infection both in epidemics as well as in sporadic situation. We also know that hepatitis E virus is a predilection to pregnant female, causing more often acute liver failure, threatening 2 lives. But in both these conditions, the mortality was not very high in comparison to other causes of acute liver failure. In other causes, mortality was around 70%, whereas in hepatitis A and E, it varies between 40 to 50%. About half of the patients with improved intensive care survived. We also identified who will survive with medical care, who will not, prognostic markers. But we in our country had many ALF mimics, right? Tropical diseases, which you know, which you have seen, and they need specific test. We can differentiate even clinically. Having fever with icterus and altered sensorium, the liver size is not reduced. This we also know. But what has happened? All of you are clinicians. You don't see hepatitis E anymore. Do you see anybody? Tell me in last 5 years, how many of you seen hepatitis A as a cause of acute liver injury? You are not seeing anybody. Only 1, 2, 3. Previously, everybody will raise hands. E. That's it. So something is happening. So that's why Ipan told Ajay that all this etiology is different. Ask him to talk about change in etiology. So what you are seeing is most cases of AVH are hepatitis A virus. HEB-AVH has become very infrequent, which was a major cause in your clinical science. Second, you are seeing recent reports of etiology of ALF from tertiary care center, hepatitis A virus and drug-induced liver injury has become more common in north, east and western countries. And Professor Epan told us, look, we see rat poison more often. And mortality, however, has reported similar. The cause is hepatitis, but instead of HEV, it has become HAV. ATT has remained same, and rodenticide has added to the drug. And mortality of virus-induced acute liver failure has remained same, because previously also it was similar. Now, since the etiology has shifted, majority are because of hepatitis A virus, hence mortality has improved. Survival has improved, mortality has reduced. More frequently, because very aggressive clinicians like Professor Rakhi Mayawal and Ipan and many other centers are using Plex and CRRT, and also Anand, right? And they think the survival has improved. If you ask me, I'm not convinced. I have reasons I don't have time to discuss. But you need solid, effective data about it. And another interesting thing you must observe, the epidemics of hepatitis outbreak during last 10 years, there is no HEV epidemics. Professor Rakesh Agarwal, who is the HEV expert in the world, will vouch to them for that he has no more been called to investigate any large HEV epidemics during his last 10 years, even though he has become a director and very senior professor. Will you agree with me, Rakesh? Yeah. So, change in etiology. This is the first multicentric tertiary care retrospective data. Fine, but this is the data. Now it was published by Akash. And if you see, I've just summarized this. If you see, HAV is now responsible for 50% of cause of acute liver failure. Hepatitis viruses are responsible in together 60%. But if you see HAV with dual infection, about more than half of them are causing acute liver failure. It is no more HAV. HAV has become 4.37%, which was earlier 40-45%. And hepatitis B remains. And since it is Professor Epan's contribution, you see rodenticide has become an important cause, right? And ATT. So about 20% are because iatrogenic. 60% are infections, predominantly hepatitis A virus, and 20% are iatrogenics because of drug-induced, CAM, and rodenticide. Remaining are metabolic and other miscellaneous causes. Many of them are cryptogenic, but cryptogenic causes are reducing. So this is the first large-scale tertiary care, even though retrospective. I will point out something. Very interestingly, in this study, you will not find pregnant females. There are no previous all studies, more than 50%, I will show you some data, our own data. 50% are pregnant. That is the second important observation. If you see, Anand was contributed. None of your patients are pregnant. They were HAV. Agreed? I saw that. So that was surprising. So obviously shift in etiology, people have not realized, has improved instead of 2 life to 1 effective. And this is what Dr. Epan says. And he says population attributable risk factor for rodenticide as a cause of hepatotoxicity in South India in a multicentric study was 22.7%. That's what he calculated. And he saw 1/3 of them, most patients were young, and 1/3 had 30% or 35% of mortality. Right? So that's what the change in etiology which is focused. So at 6 months in this study, about 1600 patients in 15 centers. That is about 106 patients in each center and 17% per month per year, I calculate, right? So that's a sizable number just because of one rat poison. That's a safety in etiology. Now, I have been working on since 1986. Of course, after me, Salivar is maintaining this data at AIMS. Very meticulously, prospectively, each patient's data is stored. Now, you see, during last 4 years, hepatitis A virus has become 30% and hepatitis E virus has reduced drastically from 40%. So that has happened all over the country. And then when you study it, you see I have here cryptogenic non-noni. Half of them were HEV RNA because we used to do HEV RNA. So they were predominantly HEV. If you see, both this are coming down over a period of year. And HEV is going in a center where maximum ALF was reported, where hepatitis E was a major cause. And that same center data during last 40 years has been depicted in graph, showing that this is markedly reduced. So obviously you will realize pregnant females are not affected.
Sir,
Just a minute, don't discuss. Sorry. So obviously the mortality will change. Natural. So there is nothing surprising. And way back we showed the mortality in large patients that HAV and HEV has a very low mortality. About 50 to 60% survived. And if you see the recent study by Akas and Kulkarni, Anand, the same thing. HAV has become predominant cause and the mortality is same. Right. So overall what they showed, the survival is about 60%. So because of the safety in etiology. Right. And this is what I was telling. No pregnant females. You know about epidemiology of hepatitis B and pregnancy susceptibility. Now, if you see, this is the recent paper which has collected data on epidemics of hepatitis in our country. All are hepatitis A epidemics, which has collected. No hepatitis E epidemics. Why has this happened? In India, cultural practice of food ingestion is also changing. More HIV from food handlers to young adolescent and adult is happening. I have given you, and this is the data. How many young adults are eating outside, depending upon the age. This is documented objective data, published recently. So, you are taking food more often from street vendor and outside. Ask yourself how many times you go outside to take food instead of home. Right? When you were a kid and now how you're doing. This is exactly has been documented. Hepatitis A virus has person-to-person transmission. HEV do not have person-to-person transmission. Professor Agarwal has shown it. And food handlers, right? Giving you food, which is food which contaminated, are the source. Open defecation in India is reduced. Modi ji Jindabad. He has opened toilets everywhere. So open defecation and groundwater contamination, which is shown by Professor Naik and Dr. Agarwal, was the and sewerage contamination major source of HIV epidemic. It has vanished practically. And increased toilet at homes. These are the reasons why you have a safety in etiology. Right? This is, of course, we need more data. And I have given you that how HIV also in some state is decreasing because of awareness. Childhood HIV vaccinations, right? And that is also now a need. I am showing this is a old data from All India Institute where 56% were pregnant females, and more often them they were because of hepatitis C. Now I told you recently there is no pregnant females. That is gone, right? In your study also, Professor Ipan, it was all male dominated. Males consume rodenticide. There is no pregnant females. So whole thing has changed. And in acute liver failure, there is a very interesting study from West to predict, because this has become more important cause, how to predict ALF. And most important thing is that down. Usually they have initially good albumin level. And if you see drop in albumin in serially by 1 gram has a odds ratio of 9 for developing acute liver failure. Or initially bad melt or initial low albumin are predictor of acute liver failure in HIV infection. We see also dengue as the cause I told. And dengue induces severe hepatitis, particularly when the transaminase is very high, there is a chance of acute liver failure. This I intentionally projected because our etiology is changing, also prognostic markers should change. So in summary, I will say the most important etiology of ALF in India continues to be hepatitis viruses. That continues about 60 to 70% depending upon the region. However, hepatitis A virus has become the major hepatitis virus causing severe acute liver injury as well as ALF, probably more than 50%. We need more prospective data, that is a retrospective data. HIV as a cause of acute liver failure has markedly declined. From tertiary center, it has become now less than 5%. Drug-induced liver injury and complementary alternative medicine frequency as a cause probably is on the rise. I don't know, we need more prospective data. And it may be also because of increased awareness about it. Tropical diseases like dengue, scrub, leptospira, and malarial hepatopathy remains a concern till date. In South India, rodenticide poisoning has been reported as a very dominant etiology. Overall mortality has reduced to 40 to 45% due to shift in etiology because HIV has a better survival, do not affect pregnant female and severity. Better IC care. I need more data to convincingly say, I know Raki's and Ipan's data, but I need more data to convincingly tell the Plex and CRRT better. Change in etiology from HIV to HIV is a dominant cause. Increase in non-immune population in our country. I published myself a study probably 25 years back blocking HIV immunology, which is school children from 5 to 16 in 5,000 school children in North India. And by 5 years, 80% has protective antibody and 100% by 16 years has protective antibody. That population is gone. Now all the children, even in village, take sterile water, drink bottled water. No more tap water, which is contaminated with small HIV infection, which is giving you protection. So they need to redefine that etiology. That is one reason. Increasing consumption of outside food by such adolescent and young adults, which data was shown, and the toilet habits and availability of toilets due to our Prime Minister has changed this etiology. Thank you very much.
Thank you, sir. I would like to add that even in this INASL 2025, we have shared data from my center, which is Max Hospital. Over the last 8 years, we've had, sir, a similar picture where we had hepatitis A, and we've also shared our data of course, retrospective, how many patients were transplanted and how many patients received CRRT and Plex, and those who did not receive either.
I know that. I know your data.
So
Professor Piyush Sahni works there now.
Yeah.
And he has been my colleague over the last 40 years.
Yes, sir.
And he asked me first thing this, Dr. Acharya, what is this? We see all HIV. You have been telling us all HIV. Only things have changed. I know you that. Thank you.
So, sir, do you recommend that we should now see the antibody levels and start and include hepatitis A as part of universal?
I believe so. I believe so. I think things have changed. Everything has changed in hepatology, right? Now, Madhuvita says cirrhosis can be recompensated, right? If you treat the etiology, right? Rakhi and Gaurav says treat ascites, forget about recompensation. But things are changing.
Sir, I think we should, as INASL as a whole body, and with Dr. Professor Ipan, Dr. Acharya, we should do some initiatives to start vaccination for hepatitis A.
Yeah, I agree with you.
Seeing a lot of hepatitis A patients very
I know that, and in adult and young adolescent, hepatitis A has an unnatural course, prolonged hepatitis, right? Severe hepatitis, cholestatic hepatitis, relapsing hepatitis.
Is it
right?
something to do with COVID or vaccination? That's the
I
frequently
don't know.
asked question.
I cannot.
By
Rakesh will be able to answer because he is the epidemiological expert. Rakesh, your comments?
This has nothing to do with COVID whatsoever. somehow in India we seem to be getting surprised by this. This is something that has happened in most parts of the world over time. We are seeing it somewhat later because we were more unclean. This has happened all over the world.
I know, that's happening.
Basically, with hepatitis A epidemiology, we need to remember three things. The poorer the sanitation, greater the transmission. And especially everybody used to get infected at young age. The second fact is, once you get infected, you get lifelong immunity. So if you get infected as a child, you'll never get infected as an adult. Third, the disease is more severe if you get infection at an older age. So it's a well-known phenomenon for many other diseases. It's true for chickenpox, it's true for many other diseases. So that is what is happening. Many people have not realized that we are becoming cleaner, and it's not today. When I was a child, every 4 or 5 years there used to be an outbreak of infectious viral conjunctivitis. Many of you would not have seen those outbreaks, right? So things have changed. The same thing has happened with herpes, the same thing. And the other big misbelief in gastroenterology community is that hepatitis A spreads through water. That hepatitis A and E are similar. No. Hepatitis A spreads person to person by close contact. So in the US, the child goes to a what we call creche, they call, what do they call it? Whatever, daycare center, and they get infection, they come home and everybody in the family gets infected.
That's very important to understand,
It's
actually.
not water.
Yeah.
The reason is, for hepatitis A, you need very few virions. So even if you wash your hands, etc., a few virions remain and you get infected. Whereas for hepatitis C, you need a large dose of water of virus. That's why you need water, and person-to-person transmission does not occur. So what is happening is, now we are not getting exposed in childhood. There are greater number of people.
But Rakesh, his question is different. His question was, should you start HIV vaccination?
No, there is a dangerous area. So I was posed this question about 25 years ago when my daughter was small. And I decided not to vaccinate her, partly because I am somewhat of a communist or socialist. My problem was that her risk will be reduced, but the children, maidservants, children who play around with her, their risk will actually increase. If you do vaccination of 50%, the transmission among that group will reduce, and a lot many people will grow up without having been exposed to the virus. So this is exactly what is true for rubella. Exactly the same thing happens. So you have to have a vaccination coverage rate in excess of 80%.
80%, that's correct. That's very important.
If you and I start doing it for our children, actually we will protect them. But as a community,
Rakesh, that is exactly happening. Because educated children, now you are getting delivered in hospitals, nursing home. Now home delivery is increased. And in home delivery now there are two physicians. One is a pediatrician and one is a gynecologist.
And the second thing,
everybody now the pediatrician tells you about HIV vaccination.
And everybody thinks we say and the vaccination will happen. Can anyone give me a rough idea of how much COVID vaccination cost India? Rough figure. I am fine if you are tenfold less to tenfold more. How much do you think COVID vaccination cost?
I know
India?
47 crores were given by ICMR to
47 crores is nothing, sir. No, I'm not giving vaccine to each one of us. How much did it cost? Guess? Guess, anybody? Rough guess to start off, ballpark figure? 500 crore. You are off by a...
No, you see, there are 2 doses.
Just a minute. We gave 200 crore doses at least, right? Each drug purchasing was somewhere around 250 rupees each. And the cost of administration is actually more than that. But even if we take 250, 500 into 200 crores. 1 lakh crore. That is 1 month's GST collection. Nobody seems to realize that vaccines cost. So for the country to introduce hepatitis A vaccine, how many of us are okay if our income tax increases by 10%? Raise your hands.
But it doesn't matter.
To get hepatitis A vaccine to everybody. Anyway this is the problem. See, everybody thinks that people are not realizing how much COVID vaccination program cost. 1/12 of annual GST collection was spent on COVID vaccination. None of us has realized. Unfortunately, that is the problem.
Thank you, Rakesh, for that. Another lecture.
Okay. No, but that's how it is.
Thank you.
It's not easy to introduce a vaccine at 80%.
So, although this is very interesting, but we would like to take this forward, and I would like to call Anand to talk about corticosteroids and severe alcoholic associated hepatitis. Please give us some new insights on this, Anand.
Thank you so much, ma'am. It's a great honor to speak here. Thanks to Ajay sir, Sunil sir, and team PGI for inviting me here. It's a favorite topic for me, steroids in severe alcohol-associated hepatitis, and what are the new insights. Sana, my slides, please. So the burden of alcohol consumption is pretty high. This is the Indian data. Everybody thinks that Punjab is the highest data. Punjab is not. Arunachal and Telangana, we rank first in consumption of alcohol. And we also drain a lot of patients from Arunachal, Sikkim and Manipur. So we have the highest number of patients who come to us with alcohol use disorder also. Although on the left side, right side, you see that urban, rural areas, the consumption of alcohol in women is little low. Again, Telangana is at fourth number. But when we did our own, we are still continuing this rural initiative for our in Telangana. What we noted is about 1,700 individuals which we have assessed till now in past 3 months, alcohol use is 65.5%. Every man, every adult, every woman will drink alcohol. They drink toddy for sleeping purpose. They say that when I come back home, I am feeling tired. I have to drink alcohol. It's quite high. I don't think it is 1.9%. It must be little higher than what we actually are seeing in our routine practice. Coming to severe alcohol-associated hepatitis, it's a disease which has very poor outcomes. It has a mortality of more than 50%. And as you heard yesterday by Dr. Ashok and Alex Louis, the transplant is the best therapy. And early transplant has increased by almost 5 to 8-fold in the last decade in US. And alcoholic hepatitis and ACLF are one of the leading indications for transplant. But the cost of this transplant is $3,000 in US, and it's also pretty high in India. So we are left with only medications for most of our patients because we don't have the feasibility of transplant for all these patients. So there is an urgent need for identifying good drugs for severe alcohol-associated hepatitis. But we are still struggling. The number of studies on alcoholic liver disease only hardly 121 compared to MASLD, which has more than 1,000 trials being conducted. There is no definite animal model, although there is a small few studies, although these are all expert opinions saying that binge model with continued alcohol consumption should be used for animal models, but there have been no evident models which have been recommended to be used. The disease is very heterogeneous. The study by Dr. Rakhi also showed that most of these patients has ACLF, they are sick, they have only extrahepatic organ failure. Hardly 20 to 25% will be eligible for corticosteroids or any other therapy as such. The pathophysiology is, we know that we have to target the drugs, but it is very heterogeneous. It goes from gut microbiota, changes in gut microbiota, there is some change in the liver. It's all related to inflammation. That's the reason we are left with only one drug. So this is a quote I had taken from Mark Thur's paper recently published, whether justified or not, because most of our colleagues don't agree that corticosteroids are the backbone. Whether justified or not, corticosteroids have remained the backbone of treatment for alcoholic hepatitis for more than 30 years. This is also a conclusion by Alex Louis, who showed that waiting for new and confirmed studies, treatment of severe alcohol is still based on prednisolone. So that is the reason I am talking about steroids today. But everybody confuses that alcoholic steroids was initiated by Madris. It was not Madris. It was actually Richard Hellman in 1971 who initiated the use of steroids in alcoholic hepatitis. But the aim in the initial studies were all different. They said that cirrhosis should be reversed. Somebody said portal pressure should be reversed. Somebody said we are not clear what has to be done for alcoholic hepatitis. So suddenly then Madris said, I think it is all about liver function test. Bilirubin decreases. There is some survival benefit. If the Madris score is more than 32, or if the patient has hepatic encephalopathy, these are the individuals who will benefit. So in clinical practice, if you see a patient who has HE, don't say that this patient is not fit for the therapy. He is a patient fit for steroid therapy, provided he doesn't have infection. This is a most commonly a mistake made by our students, that HE we should not initiate steroids. So HE should be an indication for steroids in alcoholic hepatitis, provided without any infections. Then we had learned that MELD is also better than MDF. Then Louis also developed the Lil's model, saying that patients who have Lil score less than 0.45 at day 7, they have significantly better survival compared to those who have more than 0.45. One thing about Lille score, it's very tricky. You just put out the Lille score. If the age is less than 47, the patient becomes responder even if the bilirubin remains static. If the age is more than 48, the patient becomes non-responder even if there's decrease in bilirubin by 2 points. So the age has a lot of weightage in Lille score. That's the reason we are usually avoiding steroids in patients who are aged more than 48 to 50 years. So from the past, we learned that corticosteroids cannot reverse cirrhosis, they cannot reduce portal pressure. That was not our aim. But they improved survival in those with HA and DF more than 32. Also, we need to have some good nutrition because 21 calories was the suggested amount required for these patients for recovery. Sick patients with renal failure cannot benefit from corticosteroids. One struggle in India is also the prevalence of tuberculosis. We also are doing gene export for these patients, TB gold spot, to identify patients if they have occult tuberculosis. And MELD is also sufficiently accurate to identify patients who will benefit from steroids. And Lills can predict 6 months mortality. Yes, these are the lessons we learned. But there is difference in use of corticosteroids worldwide. 80 to 85% of physicians in US and Europe use steroids, but whereas in India, Asia, it's only 40 to 50%. The reason for this differences is actually the risk of infections which we are actually struggling with. Almost 25% of patients will have infection at baseline, and more than 25% will also develop infection after the initiation of steroids. But if you have a patient who is infected, if you treat them adequately, his survival is better even if you are treating with corticosteroids. So patients who have infections is not strong contraindication. They should be adequately treated and then can be initiated on steroids. Then we started changing our focus. We thought we should reduce infections by adding something to steroids. So we started adding NSL-16. We found there is some reduction in the HRS, there is some reduction in the infection. Again, no mortality benefit at 3 months and 6 months. Then we started adding antibiotics for these patients along with corticosteroids, and we noted that there is some reduction in the infections for these patients. Again, no much great mortality benefit for these patients. We also added omega-3 fatty acids and then noted that there is some reduction of infections, but no, again, mortality benefit. So then we thought we are struggling with something else over here. We have added antibiotics, we added NSL-16, we added GCSF, then STOPA came out saying that there is no much benefit of steroids. The p-value is 0.06. So it's something to do with the dosing of steroids. It's not something to add. We have to just modify the steroids. Then we went through the guidelines. All the guidelines said that 40 mg, this was all arbitrary made from the studies which were published in 1970, saying 40 mg for 4 weeks. Either you stop or either you taper after 4 weeks. But when we look at the literature on SLE which has rampantly used steroids, they say the longer duration of steroids will lead to suppression of NFKB and increase the risk of infections. So you have to taper steroids early in those patients. There is some literature which is published in lupus journals. So that's then we got together and prepared this study called a STASH, which was recently published, where we started patients on 40 mg for 4 weeks and then we stopped it immediately. Or the other group which received 40 mg for first week, 30 for second, 20 for third week, and 10 for fourth week. This was a multi-center study. I'm very thankful to my friends who are over here. What we noted in this study was there is reduction in the incidence of infection. We did competing risk regression analysis also. We had multiple therapies which have been used. Even then, there was reduction in the infection risk with the use of steroids. A major concern which Dr. Alex also mentioned yesterday was there is delayed infections which have been reported. It is probably because earlier patients were on under scrutiny, they were under strict surveillance, but later on when they missed the surveillance, they had increased risk of infection. However, I am not very convinced because I have seen the gastro papers. All the papers say that even with 7 days of steroid therapy, there is increased risk of infection even till the day of day 90. It doesn't occur immediately because there is some cytokine modulation which occurs in these patients. Steroids actually lower the cytokine production but upregulate the cytokine receptor expression. When you are slowly withdrawing these steroids, the cytokine release returns to the normal in an environment of upregulated receptors. So tapering may allow more regulated and gradual recovery of the immune system, where sudden stopping may lead to increased risk of infections. This is what we have got from SLE as well as transplant papers, which have suggested that we have to taper the steroids, not increase and continue the steroids. We are also continuing this aspect as STASH2, which reduced dose of steroids for 7 days versus 14 days. We have compared few patients, and we have been noting that there is again increased risk of infections after the day 30 itself, which doesn't occur within the first 20 days. Then there are certain markers which have been used. Several studies, metabolomics, proteomics, everybody has their own way of identifying the markers. We have been trying to identify a marker, but we have been not been successful because all these patients are very heterogeneous. It all ends up to patients' clinical parameters and organ failures. The only one thing which is found relevant, which we also are finding very relevant, is serum keratin 18 fragments, which was TOPAZ subgroup analysis, and they have noted that there is CK18 more than 5 are the patients who will respond well to therapy. The other study on NLR, which also was published on STOPA, saying that NLR between 5 to 8 will respond very well to therapy, was also, we could not find such associations in our population. Performance status of a patient. If a patient is very sick and he is on his bed bound, has grade 3 ascites, obviously we will not start them on therapy. These are all not patients who will be requiring corticosteroids. Hardly 20 to 30% will be eligible for steroids. But if the patient has a good performance status, he is able to come to your OPD, he is able to do all his routine chores, then he is an ideal patient to receive corticosteroids because they respond well to therapy. So this is a checklist which we have prepared for our patients. The patient who has age less than 50 years, good performance status. Hepatomegaly, the presence of inflammation, large liver, small spleen, very mild or minimal ascites or ascites which is adequately controlled, who has no varices or probably early varices. Encephalopathy is okay for us. Resolved AKI, and patient who has sepsis will obviously not be given on steroids. But last but not the least, prescribe and follow up. Don't forget, he requires adequately, he has to be under surveillance when you start them on steroids. It is not like you just prescribe him and tell him to come after 1 month. So every 7 days, this individual has to be followed up regularly. To summarize, corticosteroids still continue to be the drug of choice for alcohol-associated hepatitis. Infection screening is must before initiation of steroids. Clinical assessment is important, and newer therapeutic drugs are, although there are certain last sarcosterol which has come up in the recent studies, has shown benefit in US population, not in UK population. And last not the least, we should not forget alcohol use disorder. We have been using naltrexone for these patients. They do pretty well with naltrexone. Prevention is better than cure. We need more policies, as I discussed before also, for acute liver failures, alcoholic liver disease, which is rampant in our country. I take this opportunity to invite you all to our liver meeting, which is happening on next month on 26th and 27th of September. Thank you.
Thank you, Anand, for finishing very well in time. And because of paucity of time, I want to invite Dr. Ashish Goyal for talking about plasma exchange in ALF and ACLF.
Thank you to the organizers for the kind invite, and I'm aware that I'm the tail ender here in the INASL conference. So let me start as soon as I can. Okay, this is the slide that Dr. Acharya projected. Is basically a study across 6 centers in Tamil Nadu in 6 months in 2019. And what we had noticed was around 451 patients of rodenticidal hepatotoxicity. And out of these 451, where 1/3 did not survive, only 1 underwent liver transplant. So definitely, liver transplant can't be the answer in the entire cohort of patients with acute liver failure in India. What we all know is, when indicated, liver transplant definitely is best option, but it's not feasible. So there is the role for liver assist devices, and whenever there are liver assist devices, what we are aiming to is either bridge to spontaneous survival, or either we are bridging to liver transplant. Most likely it is bridge towards the spontaneous survival. So why do plasma exchange for something within the hepatocyte? So this is the study that we have just published, where we showed that a plasma-driven monocyte dysfunction is what is causing disease progression, and this is in alcohol-related ACLF. So looks like the plasma is also toxic in these patients. So this is plasma exchange. It consists of two things: removal of plasma and replacing with fresh frozen plasma. We use volume matched fresh frozen plasma for our exchanges. And in doing a plasma exchange, what we are hoping that the milieu on the right side, on your left side, where the milieu is very inflamed in acute liver failure, is restored towards health, where the flow is restored inside the liver sinusoidal endothelium, liver sinusoids, and this allows the hepatocytes to start rejuvenating. So this is the first randomized controlled trial on usage of plasma exchange in liver failure. This is across 13 European centers, came out in 2016 on high volume plasma exchange. Now each exchange was around 8 to 12 liters per day, and they did 3 such exchanges. They randomized 90 patients to a standard medical treatment versus Plex, and it becomes difficult to interpret when there is a transplant option available. But what is shown is around 10% improvement in 3 months survival in patients who do not undergo liver transplant with high volume Plex. Subsequently, Dr. Akhi's study on mainly viral hepatitis related ALF on standard volume Plex, which is around 1 to 2 times the estimated plasma volume against standard medical therapy, and there she showed around a 30% 3-week survival in these patients with standard volume Plex. Now, based on these data, the American Society of Apheresis actually recommends as a category 1 indication of high volume plasma exchange in patients with acute liver failure. We had our preliminary experience with rodenticide hepatotoxicity of plasma exchange, where we did for around 110 patients. We looked only at the pediatric group for this paper. There are no transplant criteria for rodenticide hepatotoxicity per se. So one of the criteria that was given from Kochi was MELD score more than 36 or INR more than 6 or hepatic encephalopathy. If any of these criteria is fulfilled, there is 0% chance of survival without transplant. So in our patients, where we had a small number of patients fulfilling this criteria, 67% patients in pediatric age group and around 50% patients with all ages survived without transplant. Only with we do a low volume Plex, which is around 0.5 times the estimated plasma volume. So it is not comparable to the liver transplant, which still has 86% survival in this subgroup of patients, but it is much better than 0% survival without transplant. So this data sort of spurred the Tamil Nadu ISG group to come up with a guideline to manage rodenticide and use of plasma exchange in this. We defined our criteria where we said severe liver injury, which is severe ALI with INR more than 4, or hepatic encephalopathy ALF is less likely to survive with a conservative management. This patient should undergo or should be thought about a plasma exchange, especially if there are no liver transplant options. Patients shouldn't be reaching futility stage. Based on this guidelines and the preliminary data, Tamil Nadu Accident Emergency Unit under National Health Mission Program took it up across Tamil Nadu. Various district hospitals started developing hub and spoke model for rodenticide hepatotoxicity and delivering Plex in these patients. In 2022 and 23, we had around 1,200 plasma exchange done for this rodenticide hepatotoxicity and severe liver injury. And to just compare, we only had 3 deceased donor liver transplant during the time. So plasma exchange does improve liver survival in acute liver failure, and it is native liver survival. This is a recent meta-analysis which was done by one of our fellows from Sri Lanka, and we had, as I said, 2 randomized trials and multiple cohort studies. We only used cohort studies which matched controlled cohorts, and we looked at specifically looking at etiology specific ALFs, because etiology plays a major factor in ALF prognosis. And what we found was irrespective of what volume do we use, the survival benefit is around 30 to 40% in these patients, irrespective of the etiology, if you have a comparative cohort. There was a recent retrospective multi-center study from UK. They had 7 transplant centers who had collated their data on all patients with ALF who had undergone plasma exchange, 120 out of 378. And what they looked at is, even though plasma exchange improved hemodynamic stability, in a propensity score matched analysis, they did not find a survival benefit over standard medical therapy. Now, problems with this data is, one is they are all transplant centers. So the patients who are going in for plex maybe are too sick for transplant, or they have been rejected for transplant. And most of them did have cardiorespiratory failure to start with. So we did a multicentric study, and as Dr. Acharya pointed out, it is hepatitis A, which is more common now. So we did across 13 centers across India, AIMS, PGI, and other institutes. And we had around 100 odd patients with plasma exchange with hepatitis A related liver failure, all in hepatic NKF, and we compared it with standard medical therapy. And as was pointed out, hepatitis A is a relatively benign etiology for ALF, and we had almost a 65 to 70% survival with or without plex. So essentially, the primary outcome of survival benefit in overall patients was not there. But if you look at patients not on inotropes, so not very sick patients, but not on inotropes, plex starts to give us signals where the plasma exchange may be helpful. So it may be a window of opportunity in these patients where we can introduce plasma exchange. And this is what has been in the INASL guideline, which is in 2017, that it can improve transplant-free survival and can be considered, especially in patients who are not unlikely to get liver transplant. But in ACLF, the data is quite heterogeneous and it's not always smileys. So ACLF is more over the place. We had a sort of a short review on this. The initial data, one from the ARC database, where they did a propensity scored matched analysis on plasma exchange versus SMT, did show a lot of benefit in patient survival benefit with plasma exchange. And our data also suggests that centrifugal plasma exchange did improve survival in ACLF, almost a hazard ratio of 0.29 to 0.33, and this showed a data which is showing survival benefit up to 1 year. We use, as I said, low volume centrifugal plasma exchange, and we do combine it with a small dose of steroids. As Anand pointed out, most patients will not tolerate 40 mg. We give around 10 mg of steroids in all of our patients. So it is steroids with steroids with centrifugal technique of plasma exchange did seem to work in a cohort of our patients with alcohol ACLF. But not all centers have similar experience, and the centers from the study from AIMS and from PGI did show a bit of benefit, 63% with plasma exchange versus 47% survival with SMT. Similar data from PGI, but it did not reach significance. We did a meta-analysis on this plasma exchange in ACLF. We have got a few randomized control trials, 4 randomized control trials, and I'm not presenting them because they're all on hepatitis B subgroup of patients and from China. So they are not the typical ACLF patients that we are seeing, but there are 4 randomized trials on ACLF and multiple other comparative cohorts. We did see that the plex-treated patients with ACLF have improved 1 month, 3 month, and 1 year survival as compared to SMT in the meta-analysis. But as is true for all procedures and all invasive procedures per se, there will always be a window of opportunity. Beyond a certain point of time, we will lose that opportunity. And this is what has been sort of come to consensus in Kyoto, where they said that if a patient with non-cardiorespiratory organ failure, that is the group of patients where we can try plasma exchange or any other supportive therapy. Whereas if we have cardiorespiratory failure, this is the patient where we may not be able to these procedures may not be successful. So this is what we had initially proposed as well, that depending upon what is your primary treatment option and depending upon the severity of illness, if the patient has ALF, it looks like transplant is the way to go. Most of the patients will not be able to access liver transplant. So in that case, it will be plasma exchange as a fallback option. Severe ALI, we can still try plasma exchange. In ACLF, again, in earlier stages, you may want to go with the plasma exchange. And in late stages, if liver transplant is not available, you may still want to go for rescue plasma exchange. So we have found a plasma exchange to be useful in our group of patients. And you can see acute liver injury, liver failure, which is 55% of our patients. Most of them are rat poison, and acute chronic liver failure constitutes around 45%. And we have more than 700 patients who have undergone plasma exchange. Now, the trick is, in our patients, we are doing it mostly out of ICU. So most of these patients are not having cardiorespiratory failure. This is most of the patients we are having with liver failure and coagulation failure with or without hepatic encephalopathy. So summary, Plex works by breaking the inflammatory injury cycle and is a treatment option for native liver survival, and most studies will peg it around 20 to 30% incremental liver survival over the standard medical treatment. ACLF disease per se is very heterogeneous, and most studies are definitely required. Most studies are required to know the dose and the duration of plasma exchange and what is the optimal window in these patients. Thank you.
I think we have 10 minutes for discussion. Yeah, so
Dr.
Dr.
Ashish,
Naren.
thanks. Hi. So in patients with ACLF, suppose patient is there in ward, no vasopressors, no AKI, urine output is okay, but blood culture shows something. So can we do plasma exchange in those patients?
I'm so sorry, I didn't go into details of the selection, but for us, sepsis is a contraindication for plasma exchange. We will do surveillance cultures in these patients, and if they are positive, we will not offer till it is cleared.
Thank you.
Sir, my question is regarding the stopping role for stopping this plex in ACLF patients.
So it's not, again, it's not fairly well defined, and we usually do 3 to 4 cycles in these patients every day, and then try and reassess whether we have made a benefit. 2 publications that we have done is a 20% decrease in MELD score did predict survival in these patients.
Thanks.
So Ashish, 2 or 3 things. Firstly, the data where from the West, the exchange volumes are much larger, whereas our exchange volumes are much smaller. And one would expect that if we have a smaller volume change, it would be difficult to pick up a difference. Why I came up, I think, was more to try and illustrate why in the absence of a trial, it is difficult to believe this. So it sounds very easy to say that so many patients were treated with Plex and X proportion of them improved. And of the remaining who were not treated, a Y proportion improved and Y is smaller than X. The way, if I put my epidemiology hat on, a patient comes to the hospital. Let us say 100 patients come. Even if we were to decide to do Plex in all of them, arranging Plex takes a few hours, maybe 6, maybe 8, maybe 12. Now, let us say we are able to arrange in half of them. What happens is so let's say in 50 we decide to arrange Plex and in 50 we don't. In those 50 where we decide to arrange for Plex, firstly, when a physician decides to arrange for Plex, he is aware that the person is going to survive for that much time that we will take to arrange this. Whereas if the physician thinks that's not going to happen, they are not going to arrange for Plex. And again, while we are arranging Plex, some more die. So what would happen is those who are able to receive the clock starts at a different time for the 2 groups. And that's why there can be a fallacious feeling that those who received Plex did better. I'm not saying that there are operates in this, but I just thought that, these are things that have been done at one time when I was a resident. I'm talking about 1980s, when people were doing studies on endoscopic therapy for variceal bleeding versus no treatment for no endoscopic treatment. This was exactly the problem. We've gone down this lane earlier. In 1980s, again, when I was a resident, Dr. Acharya and others of that age, there aren't too many of them here, would realize that people from UK would come here and talk. King's College would come and talk to us about a device that would, where the blood would circulate through an improvement. And 10 years down the line, they found that actually all that improvement was just improvement in nursing care. Just like you are finding that a lot of your cases that you are doing Plex now are out of the ICU. So what is happening is, it would always increasingly look better. So those are the challenges. Thank you.
I understand that, and I may not have enough information currently to answer you, sir. So I'll take that point, sir.
So I think I'm really sorry about this, but there's the valedictory function which we all need to proceed for, and we have a lot of comments and discussion can continue later.
Thank you.
Right, on the way. Yeah. Thank you. We'd like to close the session, please.
I request the speakers to please come up on stage along with the chairpersons for a photograph. Thank you everyone for your active participation to INASL 2025. Let's validate in Hall 1. Please move for a valedictory session. Thank you so much.